Um, so basically, I'm delighted to welcome Dr. Shobhit Baijal this morning. Some of you may remember that Dr. Baijal spoke at one of our patient forums a couple of years ago now, maybe even 3. So, but for those of you that don't know, Dr. Baijal is a medical oncologist based in Birmingham, and his specialist areas are lung cancer, precision medicine, targeted therapies, and clinical trials. So welcome, Dr. Baijal, and thank you very much indeed for giving up your time to answer all our questions on this important topic and what it means for us as patients. Your audience today is actually made up of a mixture of both ALK positive and EGFR positive members. And we also have Jenny, the chair of EGFR, online as well. So Dr. Baijal, would you like to say any words before we kick off with the questions?
No, just to say thank you for the invite to speak today, and I think it's great what you're doing, and also Jenny, and yeah, more than happy. Please ask away. No question is out of bounds. If I don't know the answer, happy to look things up and get back to you, but yeah, I'll give you honest answers on any questions you want to ask, and it doesn't have to be limited to, I know the topic is focusing on NGS, but happy to talk about things outside of that if it's relevant.
Thank you very much. So Jenny, would you like to say a few words?
Oh, just to say, Dr. Baijal, thank you very much indeed for agreeing to give us your time this morning. I think it's a very important topic, and I know that we're all going to learn a lot, and that will all help us as patients, I think, advocate better for ourselves. So thank you.
So if anyone does have any questions, then Jenny's going to monitor the chat function, and so she'll pick those up towards the end if we've got any time. So so without further ado, I think I'll start with the first question, if that's all right. Baijal, so when someone is newly diagnosed with lung cancer, a biopsy is taken for testing. What is this test called? And then following on from that, what information does the test provide, and how does this inform the treatment plan? Is the test carried out on all NHS patients? How long does it take to get the result? And should patients start chemotherapy whilst waiting for the results? There's quite a lot there, so we're happy to break it down.
No problem. So if we take the first part of that question, so when a biopsy is done, so really the biopsy, in terms of, if I understand that question correctly, in terms of what is it called, it really will depend on where the sites of disease are, and that will determine the type of biopsy. And that could involve either having a camera down with what we call a bronchoscopy, or even a bronchoscopy where we actually sample the lymph nodes in the middle of the chest, something called an EBUS. Other times we might go with what we call a CT guided, where the patient will go down to radiology, and a needle will be put in from outside into the tumor. That could be, and again, could depend on where the tumor is lying, could be in the chest, could be in the lung, could be in any part. But these decisions are usually made. We have, as you may be aware, what we call MDTs, or multidisciplinary team meetings, where we discuss all cases, but we actually do have precursors to that, something called a lung investigation day for lung cancer patients. Most hospitals run one of those. That's when patients are still in that diagnostic phase. And it's at those meetings where we determine what would be, probably the best way to get a biopsy, in all honesty, especially in the current climate, and what might be the quickest way, because obviously COVID has put strains on different elements of the pathway, and also what might be the easiest accessible without causing discomfort or harm to the patient. So I hope that answers that question. I think I interpreted it correctly, and I think hopefully that answered that. So when that biopsy is done, that will then go to our pathology lab. And the first question is, have we got cancer cells in there or not? So, and sometimes we do get different findings. We think we're going down a cancer route, and we actually find out we're dealing with something else. But the first question is it cancer or not? The biopsy, and again, usually the scans are pretty conclusive, but sometimes they're not. But our pathologists may do some extra work on the cancer. First of all, there are 2 broad spectrums of lung cancer. One is small cell, which is irrelevant for your cells. That's about 20% of lung cancer population, and the bigger population is the non-small cell lung cancer population, and that's what is relevant for yourselves. And we then further subdivide that into different categories, and the majority of your cells, EGFR positive and ALK positive patients, will be in what we call the adenocarcinoma subgroup. We do sometimes find these mutations in other subtypes, but majority will be in the adenocarcinoma subgroup. So some other fine-tuning tests might be done just to confirm that this is coming from a lung primary cancer, and that's what we're now dealing with. But that's where, over the last 5 to 10 years, we've seen the biggest evolution in terms of what happens beyond that, because we're now in this era of, I like to call it personalized medicine. We're trying to find the best treatment that fits the patient. And so a whole array of tests, and that test platform is growing and growing as the years are going by. So, one of the first biomarkers that we were testing for was EGFR. But now we will, as a minimum, most centers should be doing something called PDL1, which is really, again, not so relevant to yourselves, because that's really a marker for patients, guides treatments for patients who don't have a mutation such as EGFR or ALK, and really tells us how well a patient may do with immunotherapy type drugs. And then we start looking at the mutation breakdowns. And so, as a minimum, modern day, all at least adenocarcinoma patients should be tested for EGFR, ALK, ROS1, and there are a couple of other mutations. I'm happy to go into those, but and that platform is growing wider and wider. And as a minimum, in my patients, we test for about 6, 7, maybe even 8 different mutations, because the field is expanding so rapidly. And I hope that answers the question that yes, there is variation in the UK. I think EGFR and ALK, I would hope, is a given nowadays. The other mutations, there is variation, and uptake does vary, but because EGFR and ALK have now been established for a good period of time, that I can't imagine there is a centre that isn't doing those tests in the UK. Did I miss any of those questions?
I've got a couple of more, so thank you. You've remembered very well. So how long does it take to get the results for these tests?
Okay, so this will vary from centres, because it will depend on whether your hospital or your trust can do the test in-house, or whether it has to send it to another unit. And that also then adds a travel factor to it. So I would say, from the moment of pathology, if a biopsy is taken, I think the average turnaround time in my practice, and I would say is probably about the average for the UK, I would say from a patient having a biopsy to then having all those results ready, I talk about 2 weeks time frame. There is variability on that. Sometimes biopsies need retesting. Sometimes a test will fail, so the lab may have to repeat it. But I would also say that, and I know this is probably a hot topic for today, but the classical way of testing this was to do these tests, not so much in sequence, but you would do EGFR, then maybe not then ALK, but the ALK will be done in a separate, by a separate method or a separate person. So they're kind of being done not as one platform test, but it could be that, say, if I said, look, to my pathologist, I need PDL1 urgently, do you know the result? They could give me that maybe in a day or two. Have you got the EGFR? Okay, I could get the readouts maybe as we go along that. So you don't always have to wait that 10 days to get everything. And there are ways. So if I was worried about a patient that I needed, that especially if I had a feeling, that there might be a mutation here, but they are clinically unwell, a phone call to your pathologist, and I have very close relation with mine, and they know if I need something urgently, these processes can be expedited. But if it has to play itself out naturally, a kind of 10 working day turnaround time is normal. Again, there'll be variation in the country. I think there are places, and I've heard in meetings, some places do take longer. And as I said, some of that will be guided by the in-house ability as opposed to whether it has to be outsourced to somewhere else.
Okay, we do know of several members who've had to wait a considerable length of time, a couple of months for their results. And I think now, with the advent of COVID, and as you said, it's, hospitals are still trying to get back to where they were pre-COVID. So, we're just, in the advent that these delays occur going forward, should patients start chemotherapy whilst they're waiting for the result?
For me, it is as much as possible a no. But there are some, there are some disclaimers in that. So if I know we've got a biopsy and it's got cancer cells in it, because there are different scenarios that can play it, and there's cancer cells in it, and I was worried about a patient, I know that I can put pressure on my pathologist to get these read out quicker than I can actually start someone on chemo. If I said, look, I really need to know as a baseline EGFR, ALK, ROS1, and PD-L1, I can get that done in a few days. So, and I would advocate, and every oncologist knows how to get hold of their pathologist. So, months sounds scary to me, and I think that's, I don't know what the scenarios were, whether there were mitigating factors that drove that, but that sounds, very out of the norm. So, but the scenario where I would say it's different is, as I said, sometimes we do the biopsy and we might not get a reading that there's cancer cells. We might get a reading that there's cancer cells, but there's not enough tissue to run these tests. We're then in a quandary about, do we go for a rebiopsy and then do the test? And what comes into that equation really is, can the patient physically wait? So that's when sometimes for some people the cancer is progressing, unfortunately, too quickly, and you do have to bite the bullet and say, well, look, we need to start something. If we can get things stable, then we can look at a rebiopsy later. I've been lucky in that through a program or a project I was running, I had access to something called liquid biopsy for the last couple of years. And it's a phenomenal tool that really complements tissue biopsies. And that's sometimes where we can get these readouts, these mutation readouts actually on a blood test. And it really is as simple. I mean, the technology to analyze it is complex, but the actual physical doing it is as simple as a blood test. And that's something I've managed to bring into play for a couple of my patients over the last couple of years, and it's really come into handy. But it's not a standard of care. It's not something that's reimbursed. I had it through a project I was doing. But I can see this, in those kind of scenarios where you've not got a positive hit biopsy-wise, and there's not enough to run your full test. That's when you are in a bit of you've got to make that clinical decision. Is it safe to wait and rebiopsy, or do you have to crack on?
Okay, right. Thank you very much indeed. I think we've got a question about liquid biopsies coming up. So, but I'll move on to the second question, if I may. So we hear about next generation sequencing. And basically, what is it? And when is it carried out? Is it available on the NHS? And within that, are there any geographical, variations in availability? Should people be considering paying for NGS tests? And is there just one method of NGS, or are there several?
Okay, so in the traditional way of testing, so what we have, or how we've tested for these mutations in the past, has been by what we call traditional laboratory methods. So there are methods such as immunohistochemistry, FISH, PCR, but a lot of these are looking at what the cancer will then, the mutation will then express something, and we're either looking at the expression of the protein, or we're looking at how it's changing the format of the DNA. But the test is very focused just on looking at that one mutation. And as I said, it's done by these traditional methods. Next generation sequencing is actually trying to map out the whole kind of the cancer genome. And it's almost trying to get a multiple readout on all the aberrations, all these mutations in a one go method. So it's actually one test to try and get the full readout of the relevant mutations. But again, it will look at a lot of other information that could be driving the cancer, that may not be something that we have a targeted drug for. But again, we'll also pick up what I like to call a lot of background noise. So it's not a kind of, unless you get a very clear hit, it can be quite a mess to try and interpret, or will take a bit of a knowledge base to interpret it. So is it available? So there have been centres that have run their own in-house NGS panel over the years. Most 95% of the UK have been doing the traditional testing methods up until recently. A few of us, myself, and I know of other colleagues, have run our own little in-house projects with some of the companies that do NGS. So I myself have been doing the traditional, but also doing the NGS, and we'll talk about, I think you said there's some questions about liquid, but that NGS also comes into the blood biopsy and the tissue biopsy. So I've been in a position where I've been able to do that for a couple of years, or probably a year and a bit for my patients. The world is changing. There is a drive for NGS to become the norm, or at least to be offered to all cancer patients. And on the back of that, there is something called the genomic hubs that NHS England are driving. Now, they were supposed to go live a year or two ago, but it has been delayed for one reason or another, and then obviously COVID. So they are in a position that they are spread out geographically, but they are spread out so that every hospital has access to them. And they are still, the different hubs are going live at different phases. And at the moment, the ones that are live are kind of more running it as a pilot rather than fully everything is going to them. So I would say at this point in time, not everyone will have access to it. And those that don't, I would say you're not missing out as long as your pathologist or pathologist that receives your sample can test for the relevant mutations. Should you pay for it? I'll come back to that question because it's a difficult one. I'll come back to that. I think the first thing I should probably say is that there are pros and cons. So NGS sounds fancy. It is the modern way, but I would not look at it as, you know, and should it be the gold standard? Potentially, but there are pros and cons of NGS versus, you know, our traditional methods. You know, NGS, yes, you send the sample and you get a full readout. So you're kind of getting almost a map of everything in with the one test. But then that, you know, there are, and my own experience over the last couple of years by doing it does prove that, you know, there are the beauty of that is, you know, you theoretically need less tissue to do all of that. You do your biopsy and with that sample it goes in. And what we have found in occasions, not all the time, and I don't know if any of the patients on the forum have been or have had that issue, is where the biopsy goes for testing and there's enough to do some of it, but not all of it from the traditional method. So theoretically, NGS overcomes that because you, with that one tissue sample, you're able to do the full panel. But there is a requirement, something called the nuclear content that for the biopsies. And when I was doing kind of my own project, we did find that, you know, a lot of the samples that we thought would be suitable and would have been suitable for traditional testing actually were not suitable for the NGS panel. The other aspect is, it sounds like, yes, probably the turnaround time for the whole test is equivalent. We're probably talking maybe about 2 weeks to get, you know, an NGS readout from the sample going. But you've got to wait for that 2 weeks to get everything. You're not going to have that ability to say to your pathologist, well, look, can you get me at least EGFR now tomorrow or day after? You're not going to, you know, we'll lose that control and ability to expedite certain tests. And not everything can be done by NGS. So we talked about something called PDL1, which is, I know, not relevant to yourselves, but every biopsy till we know what the mutation is, we do need to know the PDL1 status, and that still needs to be done by our traditional method. So you're kind of adding another layer to the testing where you're doing a little bit with the traditional and then you're doing the rest with the NGS. So look, I am a fan of it. I've had brilliant readouts. I've had, I don't know if any of my patients are actually on the forum, but some of them, you know, we've actually picked up their mutations on sequencing, and for some of them we didn't actually pick it up on traditional testing, and some, you know, and some of that's come through also because of the benefit of liquid NGS. But you know, every test has its you know, pros and cons. And And I think there was a question about, are there differences in them? Yes, there are. There are a lot of commercial providers out there. And with the genomic hubs, it's kind of a combination between people doing their own kind of in-house panel versus kind of a mix using the commercial elements of it. Most will test for the same spectrum, or at least will cover, they cover for a whole lot more than what we actually need. So all will test the minimum that's relevant for now. And the other good thing of it is it kind of future proofs, because there are mutations that we know are coming up in the future, in the near future. And these are ones that I've got the ability to test for with my path lab because they're quite forward thinking, but not everyone has that advantage. So NGS kind of future proofs your biopsy, looking for further markers that could be relevant in the future. I think in a world where, and I've had my own patients that have self-funded NGS in the times when I didn't have it for free. I think it's a discussion, first of all, to have it. If you need it, it depends on where you are clinically. So, and you've got to be guided by your clinician whether it's worth doing or not, because not everyone needs it. So don't think all of you don't need to go out and get an NGS panel done. If you're either EGFR or ALK, you've got to reach a point where it becomes a relevant test or not. But there is still stuff that can be done in-house. But what's happening to you within your postcode might also drive what you have access to. So if your local hub has gone live, again, it's all very messy. We still don't know the clear bits of who will be legible. Can we do, for somebody like EGFR and ALK positive patients, we don't. So for a lot of patients, we might just want that one panel at the beginning. But for somebody else, for yourselves, for the EGFR patients, ALK patients, I would want to be doing them potentially at every set of progression, where we're thinking about the next line of treatment. So I have had these discussions. I've been in some of the meetings about the hubs, and it has been said that sequential testing would be allowed for patients. So, but what I would say is there's still a lot of, where you haven't got access to NGS or you haven't got a hub that's live, there still might be relevant tests that the local lab can still do for you that might actually give you the answer to what your next treatment is. So don't think all of a sudden you have to go for this, if you can't access it, you have to pay for it, but you need to be guided by your clinician on that. Is it relevant for you? Can it change what the next step is for you?
Okay.
Hope I covered those.
Yeah, and just for clarity, because you did touch on it, but just should NGS be carried out after every progression, in your opinion?
It might be that it will be anyway. I think I'm going to split your groups up now. So if I talked about ALK patients, so it's a difficult one. So if for those that are on first-line treatment, I'm assuming most of you are on either alectinib or brigatinib, and I don't know if there's anyone still on crizotinib, but majority I would expect would be on alectinib or brigatinib. Now, our default, the only drug that we can actually go to beyond that is lorlatinib. Now, there is that was my kind secretary asking if I needed a bit of fluid lubrication there, but so I would argue that from my perspective at that point in time, I think apart from academic reasons, I'm not going to change my treatment. I'm probably going to just switch you to lorlatinib. And unless there was something, and the only time then is if I felt that actually on lorlatinib, and this is my personal take, so don't take this as gospel, but then I would say, for any of my lorlatinib progressors, I will always rebiopsy. But I would agree that is really because I know I'm not going to, there's nowhere else I can go at that point in time. But if it's not behaved, but we do know there are escape mechanisms outside of ALK that can affect patients. But the beauty of something like lorlatinib is if it's going to work, we're going to know pretty quickly. So if it's not behaving as it should, then I'll be in quick for a rebiopsy. But for me, yes, definitely post lorlatinib, I would definitely want to be thinking, I know the default option then is to be thinking about chemotherapy type drugs, but I would definitely want to know what is going on to see if there is a new targeted option potentially for the patient, either within conventional treatment or within trials or access schemes. For the EGFR crew, slightly different. I would say that if, again, first line, I'm guessing there's a mix of patients, from patients who are maybe on osimertinib and patients who are on second gen, and maybe some of you on first generation afatinib, dacomitinib, lotinib, or but I would say if we take out the osimertinib group, the rest of the patients who are on either afatinib, dacomitinib, lotinib, or gefitinib, when you progress, or if you progress, we know that the majority will get the T790M mutation, and that's something that can be tested for with a blood test, not the NGS type blood test, but a blood test that just focuses on that mutation. And that's a very simple, quick test to do. And again, if it doesn't pick up on that, then doing that with a biopsy. But also a lot of the other escape mechanisms that can happen with the EGFR, potentially a lab could test with what they've got in-house. But there are other aberrations that can happen where NGS really does come into play and could guide, because osimertinib isn't just your default option. You have to prove that T790M to go for it. So for me, yeah, NGS does potentially, or at least having a deep look at what's going on, does play a bigger role for EGFR patients who are progressing on their first line drug. And definitely, if anyone is on osimertinib, on progression on osimertinib, again, no brainer for me. You've got to be looking deep at what is going on, because we're getting an understanding of what the escape mechanisms are, and some of them are targeted. We've got some, really exciting data coming through in that field. So yeah. So yes, for both camps, but potentially at different points in my practice.
Okay. We hear in the States of some patients who have TKI re-challenges when chemo fails. We know it's not standard practice in the UK at the moment, but is there a place for NGS testing in this setting, and is that therefore then an option?
Yeah, I mean, I think, and that really sits in nicely with the, where either the post-lorlatinib rebiopsy comes in, and we, I know there's a famous case of the patient moved back onto crizotinib and had a response, but we know, there are mutations that can happen within ALK and outside of ALK that might resensitize to other TKIs. I think the problem we'll always have in the UK is going to be access, which doesn't have to be a barrier, can be a barrier, but doesn't mean that we a lot of us do play with trying to push pharma companies to give us access to drugs if we think it's the right thing to do, and a lot of them do play ball. So yes, I definitely think that when you've reached, for me, if I've exhausted the TKI options, I definitely want to know what's going on at that point to see, is there anything more targeted I can do.
Okay.
But also to remember, but I wouldn't, chemo still plays an important role, and we can still see really good responses with that. So I know, it sounds alien because a lot of you have been on tablet drugs for so long, but it still can play an important role. So we shouldn't dismiss it as an important treatment option. Okay.
You mentioned liquid biopsies earlier on, but what criteria determines whether you get a tissue or a liquid biopsy? And is one better than the other?
So sadly, strictly speaking, at the moment, in terms of the NHS, no one's eligible for a liquid biopsy. We had a few murmurs about some sort of commissioning with one of the private providers, but it's gone very quiet. But we're hopeful that either one or two of them, that there are discussions going on in the background, so that we will, at least for the right population, have access to liquid, because for me it is an important tool, a very important tool, but it's not in isolation. I mean, liquid and tissue complement each other very well. So in terms of liquid, it's, I mean, the beauty is it is, like I said, as simple as a blood test, and it will give you a comprehensive readout, almost giving, again, most of the information that you would get from a tissue NGS, but it will depend on the test picking up what we call the circulating tumor DNA. And we won't always pick that, or we might not always pick enough of it for the test to read out, but usually we do. For me, I mean, I've done a lot of talk. I've got a really good slide where I show it where it kind of sits nicely in the patient pathway. But so the role where where it really works nicely, and this is where I've really seen its use is, but this is in the utopia, not when, and again, when I had access to the, my access is recently finished. When I had access to the free ones, I was quite liberal with it, but where I've really seen it work is in the diagnostic phase, where either a tissue biopsy hasn't picked up a, maybe we've not got enough tissue for a mutation to test for, and then, you know, the liquid saves me going for a rebiopsy, and we've definitely found mutations doing that. Where the tissue biopsy that's gone through the traditional testing methods hasn't picked up a mutation. But in my mind, there's still, you know, there's some demographics about the patient that I still feel that they've got one, and I've complemented it with a liquid biopsy. And again, sometimes the liquid has found more than what the tissue's found. And again, I've managed to get patients onto targeted drugs based on that. But that would be more a utopia. But I think the tissue fail test is somewhere where I think the NHS should be looking at bringing in liquid. I think that's a useful tool. You know, it may be certain criteria, maybe only for adenocarcinoma, and maybe we need to start looking at smoking. I don't know, because they will have to, these tests are expensive, and I think they will have to come with some sort of criteria. But then at the point of progression, for me, it's a very nice test to go for before going into the tissue biopsy. So for the areas where I talked about wanting a NGS for either, you know, ALK patients or EGFR patients, for me, you know, the ideal scenario is to be able to do a liquid first, because you can do it quickly. You know, the ones where we've done it, we've literally done it for the patients. They come into clinic for the scan result. We've done the liquid NGS there and then and sent it off. That's how simple it is. We kept packs in our clinic room, and we got through them, you know, very quickly. So, you know, it's as simple as that. We sent it off to the States that day the patients were coming into clinic for the results of their scan. And if it doesn't give the readout or it's failed, then we know we have to. And what I often did was we'd preempt the tissue biopsy, because we know the tissue biopsy is still going to take a couple of weeks. By then I've got the liquid result, and if from that I've got the answer I need, I know I don't need to go for that tissue biopsy. So as a standalone, it's a great tool, but not standalone. So everything complements each other, and it's again working out where the patient is in the pathway, what the disease is doing, and what you feel can add the best value at that point.
Okay, lovely. So leading on, another question that has been raised: is it possible that although no identifiable mutation has been found, another TKI might be effective?
Are we talking here focusing on ALK? I'm guessing, is that right? Yeah. Yes, the answer is to that. So I think there was a paper on this. So we have looked at lorlatinib. I mean, this is really going to be focused on lorlatinib response post alectinib or brigatinib, or as I said, even CRIS and then brigatinib and then onto lorlatinib. So it was really focused on that. And this again really drives my thought process about whether I would rebiopsy pre-lorlatinib. So what we know is that patients will respond regardless of whether they've got another ALK, an ALK resistance mechanism or not. There is a suggestion that the responses might be more durable if an ALK mutation has been identified to lorlatinib, but definitely even those where a mutation wasn't identified, there was response seen, a fairly, you know, not too dissimilar to those that didn't have a mutation. So again, and as I said, a lot of this is focused, but it doesn't take the different scenarios where we've got a different escape mechanism, whether it's a different type. So we know that, you know, an ALK can sometimes transform, you know, the histology can transform. So taking away from those, if we still know it's ALK, but we've not found a resistance mechanism, yes, so the data suggests that patients will still respond to lorlatinib. Maybe a better chance or a more durable response if we can pick up a mutation, but there is definitely a chance or fairly equivalent response even outside of that.
Okay. So you've based it, you have touched upon this, but in one of your answers before, but NICE and SMC in Scotland determine the sequence of treatments for NHS patients, and they're obviously based on the submissions made by the pharmaceutical companies. So therefore, is plain devil's advocate, is NGS irrelevant for NHS patients?
Yes and no. because I think that really rubber stamps kind of the point that I was making earlier, at least so if we again split the pathways, for me, what am I going to do if I have a patient on alectinib or brigatinib that progresses? I'm going to switch you to lorlatinib. So why would I expose you to, I think, and again, for those when I did have access to free liquid NGS, I was doing it at that point because one, I had access to it free, so it wasn't affecting my patient. It was a simple test. But also, again, it is more for understanding the disease. And there is this off chance that I might pick up another mechanism. But 99%, I'm certain I'm going to be going to lorlatinib. What I do after lorlatinib, it's an open playing field, because, if I find a different aberration, you're right, there's some of us, and I know, Deborah, those people, and Jenny, we play outside of what because we've got access to trials, or we have access to novel drugs through access, so we can get access to them prior to NICE. So with the knowledge that I know, I can sometimes play outside of what NICE. So at least for my population, I will push the boundaries. But if you've got an oncologist who is going to work just within those boundaries, there is an argument that what is it going to add? After this drug, you can only go to this, and you can only go to that. But then I would encourage your, if you are in that position as a patient, then, encourage your oncologist to look for it. And then, I always say, well, let me find what's going on. And then I'll, looking for the solution is the next challenge. Let's see if we can find something first. And then, act on that. Yeah, and then leave it with me to see if I can access the drug that I think might work for you.
Okay, it sounds like what you're saying as a consequence of what you're saying is what we've heard from other ALK experts when they've come and done similar talks for us, is that it really would be in our interest to be being managed by someone who does have a lot of experience with ALK or EGFR, so that, as you say, you seem to, you have better relationships with the pharma companies, you're aware of individual patient access or trials and various things, whereas maybe your average or general oncologist, or even general lung cancer oncologist, maybe wouldn't have as much knowledge, because it's such a wide area, disease area, being lung cancer in general. So is that something you would endorse, that as often as possible for patients to be seen by a relevant oncogene driven specialist? I mean,
I think it does matter, and we do see variations in practice, and yes, the more you see of something, that the more up to date you are with data, the more you know what you're looking for next, and it is something that, as some of us experts have met in meetings, that we've also kind of voiced this sort of platform. I think the reality might be difficult, but at the same time, what I do get this, and I would encourage patients, if maybe an easier option might be at least to get your oncologist to engage with somebody in the region who might have an interest or be a bit more of a player or key player in that area, to just run by the case and say, this is what I'm doing at this moment, this is what, and that can also work in a good way. Or patient X has progressed, what do you think I should do? Should we just go straight to this, or should I rebiopsy? But yes, and at the same time, I do have patients within the area who have come to myself, and we are very welcoming, and we're always keen. But a lot of the time also, with a bit of guidance, the local oncologists who may not be doing it too often, will be doing, it is not a bad option to do it that way, with a bit of guidance from us, or reassurance, just to rubber stamp that what they're doing, we agree with that.
Okay, excellent, thank you. So this is one, sorry, apologies to our EGFR members, but this one came through. Alectinib and brigatinib are currently preferred first-line treatments and may shortly be joined by lorlatinib in the UK. Does NGS have a role in determining which TKI should be used first line going forward?
Yeah, great question. I think, it's probably inevitable for lorlatinib to enter that arena. And I think that's probably where something like NGS will really be important, because you're right. So I think choosing out of alectinib and brigatinib, probably not a lot in there. I think, you know, you're really more driven by, you know, what toxicity profile might be worrying, you know, might be worrying me for the patient that might help me choose, or, you know, the volume of the pills, things like that. But where the mutation coverage, so there will be, you know, something like what we call the G1202R mutation, which we know is one of the key resistance mutations that can develop post alectinib and brigatinib and crizotinib, but for which lorlatinib has great activity for. So, you know, potentially if you're seeing that at diagnosis, then that might guide your treatment option on that basis. So yes, I think, you know, and also, you know, there will be subtle differences in them where, you know, some of the drugs are suggesting potentially more activity within the brain and things. So again, I don't think it's going to be, you know, it's not going to be I think, you know, something like a G1202R would almost be a given that you'd want to be going for a drug like Lorla, but other things, there are other factors to put into the equation when making that decision. If you felt that all three would cover for what you've found, then it really is about the toxicity profile and matching that to your patient. So and maybe the burden of the pills and things like that.
Okay, thank you very much. This one's a little bit left of centre, but has come through, and we have covered it off in previous talks, but not everybody will have attended those. Can you just confirm what tumour markers are and when they're tested for, and how do they inform the treatment plan, or do they?
So there are tumour markers, but not really a true one for lung cancer. So the tumour markers are antigens or elements of what the cancer is producing. They're secreted into the blood system. And so classical cancers where we really use tumour markers. So another cancer that I treat is bowel cancer. And or probably what you've all heard of is prostate cancer, where we hear about PSA. And so these are what we call tumour markers. And so that they are useful. They kind of give us a bit of a heads up just on the blood test, how the patient may either be responding to treatment, or when we're maybe, you know, potentially monitoring them and looking for progression or relapse. But the tumour marker world is, I mean, this again, I'm talking utopia here. There are more sophisticated, what I would still, they probably don't come under the tumour marker category, but we do know we talked about circulating tumour DNA, which is what we then in the blood test then look for when we're doing the liquid NGS. There is good data out there that says you can actually quantify how much ctDNA you're getting, so you kind of can get a percentage score of it. And there is both in the EGFR, mainly in the EGFR, but also in the ALK arena, really good data to show that if you start at, let's just say arbitrary number 100 of your ctDNA level when you start treatment, and then if you're responding, it will drop very quickly, and it can serve as what you could, you know, what I'm determining a tumor marker. But, you know, to do things like that, I mean, again, one of the programs we are running is with ctDNA and with my EGFR patients, where we do a sequential monitoring, and part of that has been to look at that ctDNA level and how it matches with the response and things. But you know, I would say for yourselves, that's mainly, it is a nice tool. The reality is I don't see that coming into play. So it would be a very expensive way to monitor patients. And, you know, as long as your clinician is monitoring you closely, clinically with scans, and you're flagging up any symptoms early on to your clinician, you know, it probably won't replace what we're doing already.
Okay, lovely, thank you. So I've got one final question to ask you, but before I do that, I'm going to bring in Jenny. So I think we've got a couple of questions that have come through the chat function. So I'll ask Jenny to come in on that.
Yeah, we've got 3 questions, 2 EGFR and 1 ALK. The first one is, I have lipidic pattern adenocarcinoma and EGFR exon 20. How does this combination affect the reoccurrence of lung cancer? This person had a lobectomy.
Yeah, in 29. I mean, yeah. The honest answer is we don't know. I think, you know, lipidic does carry a better prognosis. It's, you know, the lipidic pattern is almost a precursor. So I'm guessing there was probably some sort of invasive component, but if the majority of it was lipidic, the EGFR element should add an increased element of risk of recurrence. So yeah, in themselves, no, I think your statistics are what would be for the general lung cancer population for a T2A N0 M0 resected cancer. And yeah, I hope that answers that question.
Okay, then this, I'm sure everyone can read these. Are there some submutations that would mean different TKIs are indicated, i.e. that differs from NICE guidelines, i.e. if switching from alectinib, brigatinib may be indicated rather than lorlatinib? I'm of the understanding that lorlatinib covers most secondary mutations, but not all. Would NGS provide info on this?
Yeah, I think that probably was where we covered that question with Deborah, where we talked about if we, in the world where we've got all three available up front, there isn't much to call between brigatinib and alectinib. Lorlatinib does have that extra coverage, and it's a key one being the G1202R mutation. I think that's where, if we've got a world where we've got access to all three up front, then yeah, NGS may well guide what we go for.
And one from Sasha. I recently had an innovator liquid biopsy following progression on first-line gefitinib. It identified T790M, so I'm now on osimertinib. It also picked up NRSA 0.14% with suggested targeted options. When I have further progression, is chemo the next best step, or would it be better to look at targeted options for the NRSA mutation?
So, and this is where I would stress we've got it always in, so the reports are very, I'm not sure how the hubs are going to report NGS, but definitely the private providers will. It's good that they pick up these mutations, but then they will put in a lot of background info about mutations and things, and you've got to take them you've got to interpret them carefully. So NRAS at this point in time, we're not in a field where there is emerging or active. There probably are early trials looking at it, but there isn't definitely anything strongly suggesting a targeted option for NRAS. The NRAS sits in the RAS category, so there's also KRAS, and KRAS is an area of great interest where we are seeing some really exciting drugs come through. I would suggest that on Aussie progression, you get a repeat panel done and see what's driving the tumor at that point. NRAS probably isn't something to focus on, but there may be, we know that post-Aussie, there are other things that can happen, what we call MET amplification. Sometimes there are other EGFR mutations, something called C797S. So there are other mutations that can happen. It might be that chemo or a chemo immunotherapy combination is your default option, but I would also say that there are some new targeted options also coming in that post-Aussie phase that kind of target a wide group of mutations. So I think, it's an area where I think we're going to see some exciting developments. Will there definitely be, because I know I'm on verge to get a couple of them, so that there are definitely going to be some post-Aussie trials coming up. So keep an eye out for your nearest centre if you ever reach that point that you need it, because these in the early phase studies, and we had some extra readouts at ASCO, they are showing some good response rates.
Can I just add a supplementary question to this? Obviously, we're now in a landscape where, we've got first-line osimertinib here. So the more known about resistance mechanisms on other first-line TKIs are known about. But what are you seeing in terms of the landscape in resistance for first-line osimertinib, which I believe differs from what you would see necessarily in earlier generation TKIs?
Yeah, so the big players seem to be something called MET amplification, and again that's where there are some interesting studies and trials coming through. There is something called small cell transformation. So we talked right at the beginning about the two subgroups of lung cancer that we subdivide right at the beginning, small cell and non-small cell. We do see that some EGFR patients post-osimertinib cancer can transform to small cell. And that will only be picked up on a tissue biopsy, not a liquid biopsy. There is the next, so you have your initial EGFR mutation, you can then acquire T790M. We then see the next generation of resistant EGFR mutations. So there's the key one in that is something called C797S. So those seem to be the key players, but as I said, there are there are other rare incidences of things like BRAF, which again there are targeted options for. So that's where I said, it really is a place where NGS can play a very key role. And as I said, there's a combination treatment of a EGFR inhibitor with a MET inhibitor that's shown some really good, interesting responses. And it seems to be the responses we're seeing aren't just focused on MET; they seem to carry a broader one. And there's a drug also that targets what we call HER3, which, although it targets HER3, but we seem to find that in the EGFR population, they seem to be enriched with HER3 receptors. And again, it's an area post-osimertinib where we're seeing some good responses. And these are, I think, drugs which, at least clinical trial-wise, will be playing should be on the horizon in the coming months for post-osimertinib patients.
There's one more question. I don't know whether, Deborah, it's your last question or not, but there was a question sent in by one of our EGFR patients. Is that going to be your last question? If not, I will ask it now.
No, I don't think it is. Go on.
Okay. So the question from this patient was that she had a Garden NGS panel done before last October, before she started on chemotherapy, immunotherapy treatment. And should she have it redone now that she's progressed on that? Is it worth doing it again? And I think this also touches on a general question: is if you are going to have an NGS panel done, what's the recommended interval between having another one done later on progression? Is it worth having them done within 6 months of each other? Should it be a longer time period?
I would say the time to do them is, and I think, and this is where, as I said, I think it is the patients with driver mutations where I think that point of doing it is on progression if it's going to change the treatment. So I don't think there's any benefit in doing it if on a regular basis if the treatment's working and the cancer's not progressing, because there's unlikely to be a new mechanism of escape. Whether it should be repeated post chemo, I guess, would also be driven by what the Garden read out initially. And Garden would and also if you're not getting anything on a liquid NGS, you've got to think about I don't know whether it was a failed test or did it just not read any aberrations, and is it better that you go for a tissue NGS the next time? So there are a few elements to that question, but I would say if there's a chance it's going to guide your next treatment option for somebody who's got a EGFR ALK mutation, then on progression, at least you should be looking at a repeat biopsy. And as I said, it doesn't always have to be NGS. There are still, like I say, for T790M, you don't always have to go straight for the NGS. You can do that with your in-house ctDNA lab that just tests for T790M, get a turnaround in 2 days. So don't always think NGS, but it may be in the future. It will be purely that, but I would say, don't always think it has to be down that route.
So would you say for this patient, even though it had no extra aberrations, this Garden, it had what was expected, obviously chemo's now not worked, would it still be worth trying again to see if there's anything else?
I would probably say it depends what that first one said. And I said, look, I would say if the first one didn't show anything of interest, maybe to default to a tissue. I think, you are in the realms of, I think you've got to be prepared. And I always counsel people when we do NGS, you've got to be prepared. And I think in this scenario, you've got to be strongly prepared that we're not going to find anything useful. But at the same time, I think if I was in that patient's shoes or in your shoes, I would probably want to know, recheck it. And as I said, depending on what the actual readout was on the liquid, I'd question whether I go for a liquid one again, or would I actually go and get a tissue biopsy and look at what's going on.
I mean, we see a lot. I mean, this is, I suppose, final question from me. We see a lot of patients who, when chemo fails, are told there's nothing else that can be done. There's no point in doing any other tissue biopsies, liquid biopsies. I mean, what's your view on that? Should we as patients be pushing post chemo to continue to see? I mean, as you said, sometimes nothing will come back, but should we be as patients pushing and saying, actually, we don't want to stop here. We want to check if there is nothing else post chemo that could work for us.
Yeah, I think if and again, be driven by your clinician. You know, if you've got a clinician you trust and they feel, you know, again, sadly, you know, it might be that physically they don't feel that there is room to go any further, you know, in terms of treatment tolerability. But if there is, I mean, you know, I'd always say, you know, there's tumor heterogeneity. So, you know, how reliable was that first test? You know, if you repeat it, could it be something else? I mean, there is a feeling that, you know, chemo is unlikely to put a pressure effect that might change the driver mutation status. So there is, you know, there is a rationale behind not kind of defaulting to another NGS panel post chemotherapy. But, you know, again, if I was fit and well and knew I had nowhere else to turn, I'd probably say, well, you know, maybe that was a false negative. Maybe there was tumor heterogeneity that didn't pick up the aberration. Maybe it was very subclinical, and now maybe the chemo's killed off the other clones, and that other clone that was not picked up is now grown and could be picked up on a panel. It's always difficult when obviously cost comes into the fact, and I think as clinicians we start feeling a little bit uncomfortable offering treatments where the patient has to pay for it. And you know, if we could do that for free on the NHS, I think probably all clinicians will say, yeah, well, why not? Well, let's have a look, you know, and see what's going on. And as I said, I think, you know, that field, that at least, you know, definitely in the EGFR arena, that post-TOLSI field with targeted options. And as I said, for the targeted options, it doesn't always, you know, what we're seeing data-wise, especially for the HER3 drugs, they, you know, they're not always, it may not be driven by a rebiopsy based on the data we're seeing at the moment. But yeah, and fields evolve. So again, what might not have been targetable at that point may, so again, it always revisit the last report. I think the field is evolving rapidly.
Okay, thank you.
Thank you. So that brings me on to my final question, and it's really for you to sum up, if you will, please, in terms of your thoughts about the future of genomic testing. A nice easy one to end on.
I mean, I think it will be driven. I think it's coming. Well, it's here, and it's growing, and it will be here, and it will become the norm. With the genomic hubs, it will become the norm. Where it's commissioned and approved, I'm hopeful that at least for patients with driver mutations, we are going to be able to do this sequential sequencing when we feel it's appropriate on progression. But as I said, I think don't, you know, be guided by your clinician when it's the right time, if it's relevant, what's it going to guide. So sometimes doing a test doesn't always, you know, add value to the treatment. And especially if you're in the realms where at the moment we don't know where is liquid going to come into play, and if it does, how will it? So, you know, again, especially if you're in the realms of needing an invasive biopsy, be guided by a clinician whether it is relevant at that point in time or not. But yeah, I mean, I'm a big fan of personalized treatment. You know, the fields for ALK and EGFR is, as you're all aware, growing phenomenally, and we're understanding what's happening after each drug more and more and more. So the relevance of genomic testing is definitely for yourselves. And yeah, it is coming, it's here, and it will be the future.
Thank you very much indeed. So,
you're welcome.
Thank you. So we've had a great attendance. So hopefully a lot of people have learned a great deal today. I'd like to thank you on behalf of everyone that's attended today. I think you've been able to give us a really good overview, and I know myself, I've learned an enormous amount this morning. So I think we're all armed with far more information than we had before, and understand a little bit more of the NHS jargon that we come across daily. So it takes the myth out of a lot of our hospital visits by understanding all this jargon that's thrown around. So thank you very much indeed for your time. I'm going to let you go now. So yeah, gosh, good grief, we managed to keep just 2 minutes over. That's right. Not bad, is it?
I'll invoice you later. No, pleasure. I really enjoyed it, and always happy to take part in a future event if you want me back. Right.
You know, I'm going to hold you to that.
I know.
I have it on video now.
We may well too from EGFR point of view, but thank you very much indeed. It's been great to have you here this morning.
Pleasure.
Thank you very
everyone.
much indeed, everybody.
Thank you.
Bye-bye.